we will start with the next session, which will be about the preoperative management of cardiac risk for non-cardiac surgery. And you'll have to bear up with me for this next session. So it's essentially a kind of what I would say continuation of what we did last week, which was evaluation of the cardiac risk prior to a non-cardiac surgery. And this is, can we do something in the preoperative period about the cardiac risk before a non-cardiac surgery? We do know that cardiovascular complications such as myocardial infarction, heart failure, or a death which is attributable to coronary heart disease pose some of the most significant risks to patients undergoing major non-cardiac surgery. So we are quite aware that cardiac morbidity, mortality, pulmonary morbidity, mortality are possibly the two most worrisome complications or adverse outcomes after any non-cardiac surgery, along with possibly neurological. As I said, in the previous week, we discussed about evaluation of cardiac risk prior to a non-cardiac surgery, the perioperative evaluation of the coronary artery disease, heart failure, and we also dealt with valvular heart disease and what risk evaluation in valvular heart disease do we do. If you look at cardiac risk factors that would bother before a non-cardiac surgery, it's obviously things like heart failure, coronary artery disease, and the incidence or if there is the presence of an acute coronary syndrome, valvular heart disease, arrhythmias, and hypertension. Since we kind of discussed already about what needs to be done if there is heart failure, and especially about a decompensated heart failure or a resistant heart failure which is resistant to therapy. I think the take-home message that we figured out was that if it is stable heart failure, then both urgent emergency surgery can go ahead. Stable heart failure, good functional status, elective surgery can go ahead without further testing, without further modification. But it is in the decompensated heart, and if there is a decompensated heart and the patient needs an urgent or emergency surgery, you still might have some time, maybe 12 hours, 24 hours to try and compensate. But in the resistant heart failure group, then you have to really take a hard call as to whether this person should go ahead with a non-cardiac surgery or not, because the risks, the post-operative outcomes are very, very bad. You have to take a hard call, consensus opinion to be arrived at as to whether the person will benefit from that particular non-cardiac surgery. With valvular disorders, it again is about whether the valvular heart disease is the person is symptomatic or the person is stable despite even severe, not forget the moderate stenotic valve or this mild stenotic valve. Even with a severe stenotic valve, as per the anatomical definition of it, if they're not symptomatic, you can go ahead with the elective non-cardiac surgery. But if it is symptomatic, you will have to address the valve issue first before you go ahead with a non-cardiac surgery. Arrhythmias, the most bothersome arrhythmias would be the malignant bradyarrhythmias, like the complete heart block, wherein that needs to be addressed, whether with a temporary or a permanent solution, and then